Good morning. I'd like to thank Dr. Comer and the University of Kentucky for this opportunity. My name is Brendan Stack, and I am real excited to be able to speak to a lot of the otolaryngology head and neck surgery residents on the eastern half, I suppose, in the United States. During this unfortunate time we find ourselves in, I'm glad that we are all anxiously engaged in continuing in our profession and trying to improve ourselves and serve our patients the best we can, given our limitations. And I'm looking forward to this ending, and I think we're all going to be better as a result of it. And I thank you for your time, and I'd like to transition to talking about one of my favorite interests, which is hypercalcemia and hyperparathyroidism. And so we're going to start talking about hypercalcemia, and we're going to transition to the surgical side, which is the diagnosis and treatment of hyperparathyroidism. And this is a general talk, really suitable for all level residents, but does have some nuanced material at the expert level. So first of all, hypercalcemia is really a fairly common incidental finding in the primary care world that might not be totally appreciated by otolaryngologists. But some of the trends are that there's an increased incidence, and part of that has been explained by our testing regime, and part of it's probably physiological and lifestyle related, which we probably won't get into too much during this talk. Often, and I've heard this many times, the primary care people confess this finding is neglected. Many of them don't immediately know what to do with the finding of hypercalcemia. And so it's not uncommon, especially if it's in the 10 to 11 range, so it's elevated but not too elevated. They'll just say, well, we'll check again, Mr. Jones, with this next year. And so it's not uncommon that we'll see patients present who have documentation or give a verbal history of having known of hypercalcemia for many years prior to their surgical referral. Calcium levels can fluctuate a lot, and so it's not uncommon for somebody to report hypercalcemia, even have documented hypercalcemia. And then when they come in and see you and they present perhaps early in the morning when they're better hydrated, their labs may appear more borderline than outright, frankly, hypercalcemic. So these are things you need to appreciate. Really, the baseline criteria for concern of hypercalcemia is if you have someone who has documented hypercalcemia on 2 or more tests, really you ought to start thinking about why are they hypercalcemic. And if a person has a history of kidney stones, but they're not actually hypercalcemic, you also ought to think about hyperparathyroidism and think about underlying hypercalcemia and do the required workup. So if you're dealing in a population of ambulatory patients, which is what most otolaryngologists deal with, and they're hypercalcemic, the vast majority of the time these people have primary hyperparathyroidism. This ends up, if you look at large populations, having an incidence of about 1 to 3%. Now, there is some gender variation. This is more common in females than males. But you will find that incidence of hyperparathyroidism. It's typically seen as an index presentation in the 50s and more commonly beyond that. The prevalence there's predicted to be a prevalence of over 250,000 untreated hypercalcemics that are walking around with hyperparathyroidism at any one time in the United States. And it's not uncommon that these people have a insidious history of it being present for multiple years when they finally present for diagnosis and treatment. Now, if you're dealing with somebody who's hospitalized and you're consulted for hypercalcemia, the fact that they're hospitalized is not mutually exclusive of hyperparathyroidism, but you do definitely need to think of metastatic malignancy first, or sometimes not put in the bucket of metastatic malignancy, but essentially it is multiple myeloma. So any malignancy that would be causing skeletal-related events and a release of the calcium from the hydroxyapatite matrix in the skeleton would be causing the hypercalcemia in that case. But you would definitely need to rule that out. So one thing I want to let you know, and I think I've alluded to this, is this is vastly underdiagnosed. Here are two citations. Since this slide was made, 2 additional citations have been generated, one from my former institution, the University of Arkansas for Medical Sciences, one from a mass tranche of data from the VA healthcare system, shows a woeful underdiagnosis of hypercalcemia. Now, some of these may have only had one hypercalcemic event, so maybe they do not reflect true primary hyperparathyroidism. But it has been estimated by Cleveland Clinic and Herb Chen at the University of Alabama, Birmingham, that in their reviews, 75% of people that had documented hypercalcemia never went on to have a confirmatory diagnosis for hyperparathyroidism and surgical referral. So this is certainly a significant issue and probably one that's largely underappreciated. So why are we interested in hypercalcemia? Well, we're interested in hypercalcemia as endocrine surgeons because it's probably hyperparathyroidism, and that's one of our favorite things that we like to treat. But not all otolaryngologists are interested in doing parathyroid surgery, and I get that. But it's important from a healthcare standpoint to understand hypercalcemia is a disease accelerator. And if you think of hypercalcemia accelerating small and medium vascular disease, just like hyperglycemia accelerates, well, small and medium vascular disease, but it accelerates other issues related to diabetes, then it becomes a little more compelling of an argument to educate yourselves and to be vigilant for hypercalcemia. What does it accelerate? Well, it accelerates cardiovascular events and cerebral vascular events, and that's through sclerosis of small and medium-sized arterial vessels. The calcium is not coming from an extrinsic source. It's intrinsic removing of calcium from one compartment to another compartment. So what are the compartments? It's taking it from the skeletal compartment, and that would then result in osteopenia, osteoporosis over time. And this is exacerbated in females who are postmenopausal. And it's taking it to the circulatory compartment, which is why we can measure this as hypercalcemia through laboratory testing of the serum. This causes kidney stones, and probably the most significant from a patient perspective, and the most flummoxing from a treater perspective, is the variety of somatic symptoms that this presents with, which are indistinguishable from chronic fatigue, from various other types of syndromes, myofascial pain and whatnot, that can accompany untreated hyperparathyroidism. So we're going to make some assumptions here as far as patients transitioning from hypercalcemia to the diagnosis and a discussion of the diagnosis of hyperparathyroidism. What are those assumptions? Well, if you have a person that has paired elevated serum calcium and elevated PTH, and perhaps if you're very compulsive, and certainly in cases where people are suspected of being hyperparathyroid but have borderline laboratory values, obtaining a 24-hour urine calcium where total excreted calcium is measured. In the context of normal vitamin, 25 hydroxy vitamin D, and no family history of an endocrinopathy such as multiple endocrine neoplasia. These are your typical sporadic primary hyperparathyroid patients. I just want to acknowledge for the group's benefit that there are different types of hyperparathyroidism, and our discussion today is going to be confined to primary hyperparathyroidism. But I do want to tip my hat that when working up these people, you need to be cognizant that there's chronic renal insufficiency or chronic vitamin D deficiency driven secondary hyperparathyroidism, and then tertiary hyperparathyroidism, which most commonly happens in the setting of a post renal transplant patient, but can happen in chronic secondary hyperparathyroid conditions as well. So there is one foil, and although we talk about the foil a lot, I would say only one time in 100 really becomes a serious consideration. This is certainly in patients that have borderline values on presentation need to be more frequently considered, which is called familial hypercalcemia, or FHH. Just briefly, it's hereditary, it's autosomal dominant. Urinary calcium is a very helpful screening test for this disease. So, if you have a patient that's had a few high calciums, they get referred into you for evaluation of primary hyperparathyroidism. They have, quote, classic labs, which would be high calcium, high PTH, or maybe one's up and one's normal or high normal, and that would fall into more of the borderline category. You get a 24-hour urine calcium, and their 24-hour urine calcium is 50 milligrams. So that would be below usually the standard laboratory cutoff for that. Then you have to ask yourself, why is that? Well, then they're not excreting through the kidneys that excess circulating calcium. Why are they not doing that? Because this is a renal issue, and this is not a issue that would be cured by parathyroid surgery. And you certainly don't want to be doing parathyroidectomies on FHH patients. That's not good for your reputation. It's not good for your patients. It's really a futile exercise. Now, if this becomes a suspicion of yours, then you can follow up with genetic testing, just like we have a proliferation of genetic testing for Bethesda 3 and 4 nodules that we encounter from FNA and doing thyroid surgery. You can send off for a test that would be able to confirm or refute FHH. And this is very helpful because I will tell you, I've had many cases sent in to me that have had parathyroid surgery done on the outside. They present as failed parathyroid surgery. And they come into me, and I have to go through the records. I have to go through the labs. I always repeat my own labs. And sometimes I get some ambiguity in that process. And so looking for FHH, which represents a loss of function of the calcium sensing receptor, becomes very important so that I don't do a second operation on a previously operated patient for FHH, which would be tragic, of course. When thinking about surgery for hyperparathyroidism, you need to be thinking about, is this a single gland disease or is this multiple gland disease? And this is very important, obviously, for surgical approach. And this is where you start to transition from the diagnosis of the disease, which is really exclusively a laboratory exercise, to imaging for the disease, which is an exercise in surgical planning. Unfortunately, many people that deal with these patients, especially non-surgeons, have conflated diagnosis and surgical planning. And what I mean by that is that as soon as endocrinologist X or family practitioner Y may be thinking about hyperparathyroidism, they say, well, let's send them off for a sestamimby scan, which may not even be the best scan. And depending on where they send them, they may not be sending them to the best place to get the best scan with the highest fidelity. Nevertheless, they send them for a scan. They come back to the office for follow-up, and the scan is reported as non-localized. And so then they start going down a rat hole of, well, is this hyperparathyroidism after all? It's non-imaging. Well, it may be non-imaging because it wasn't the right scan that was ordered. And you just get into all of this, well, frankly, drama that's unnecessary, that is difficult for the patients, because a lot of these patients are very sophisticated. They understand, okay, I'm an unlocalized hyperparathyroid patient. My rate of failure is higher. I need to go to Florida or wherever to get specialty attention and all this other stuff. And these are all real episodes that I have dealt with in my practice. And if you're really smart about being aware about these things and navigating them during the pre-op process, you can save you and your patient a lot of heartache. So just some things to be keeping in mind when understanding primary hyperparathyroidism. This is a table from a publication that we did over 15 years ago, where we reviewed over 20,000 hyperparathyroid patients that had been taken to surgery at the time. And roughly at that time, 88%, so close to 90%, were solitary adenomas. A little less than 10% were multiple glands. And then within the multiple glands, they were pretty much equally split between double adenomas and full floor gland disease. I'm not really aware of cases of triple adenomas. I think if 3 glands are affected, really 4 glands are affected. But certainly double adenomas are not that uncommon in a high volume practice. And then parathyroid carcinoma, which is a less than 1% event, it's exceedingly rare. We won't talk about that today. These numbers have generally held true. If you look at review articles, they will alter a little bit. I would say in my practice, since I got heavily into endocrine and then subsequently went full-time endocrine, that would be 20 years' time. I would say there's been a slight noticeable change in the patients that present to me. Part of that may be because it's a referral practice, but part of it, I think, is what's going on with the disease. And what that is I'm seeing slightly fewer single adenomas and more multiple gland disease. That's the topic for another talk and some other research that we're working on. So a few comments about the anatomy. There are superiors, there are inferiors. Obviously, they're right and left. If you notice, the superior parathyroid adenomas really are more predictably located, but there's always variability. If you see that blue circle, about 80% of them are located just behind the thyroid lobe in a plain, deep tube and in a location superior to the recurrent laryngeal nerve. But there is some variability. Superior parathyroids have been found as high as the skull base and as low as the posterior mediastinum. Now, the lower parathyroid will be a headache, potentially. A plurality of the time, which would be about 44%, according to this diagram we made years ago, would be posterior to the lower lobe of the thyroid. And this is in a plane superficial to the recurrent laryngeal nerve and in a position inferior to the recurrent laryngeal nerve. But the fact of the matter is there is a lot of variability in this position. Most classically, it's an inferior variability, as the diagram shows based on the numbers. And this is where the thymus plays a role, because the superior horn of the thymus can touch and even overlap with the inferior lobe of the thyroid gland, and you can actually find the parathyroid intrathymically. And this is a phenomena of embryology. And as these patients age, and then the disease presents later in life, these intrathymic parathyroids may have continued to descend, and as the thymus involutes, these end up not being obvious in the thymus, although I found many in an intact thymus, but they may be just sort of out there in space inferior to the thyroid gland, even down into quite far into the superior mediastinum. So here's some quick numbers, a busy slide, but just shows you at the time that paper was written, the two choices were planar sestamibi and ultrasound. And it showed that there was about a 10% premium to sestamibi imaging over ambulatory ultrasound. Now, caveat here. Back then, this was planar. It wasn't SPECT. It wasn't SPECT CT. So the localization, the sensitivity has improved because of technological advancements since the majority of these patients were operated on and reported, even though the paper was written in 2005. This was historical data prior to that time. And then the ultrasounds were largely done at this period of time by technicians in radiology departments and secondarily reviewed by radiologists. And one thing that has really helped has been surgeon ultrasound and, of course, improvement in ultrasound equipment. So although these numbers are relatively unchanged, the absolute numbers have improved over time. So what's happened with ultrasound? There's certainly been an ambulatory proliferation, which has largely been driven by marketing and decreased expense and improvement in quality of the machines, adoption by providers, ambulatory providers, and using this, and specifically surgeons. It has then become a potential revenue stream as far as CPT coding for clinicians. And there is, and I'm convinced of this, I'm not aware that there's been any literature or any research about this, but I'm convinced that there is muscle memory that you develop when you do ultrasounds on patients, and then you go to the operating room and you operate on these patients to ultrasound, and then you get surgical results, and you see these people over time, and then you repeat that do loop. At least in my experience, I have developed a type of muscle memory that has helped me with localizing these patients, both with the ultrasound and then being able to know where to look intraoperatively. There's certification and training possible. You can use the ultrasound in the clinic as you're considering planning for this patient's surgery, or you could even use it intraoperatively or both. We won't delve in. Those are talks in and of themselves as well. So I want to introduce to some of you, and probably now it's not as much of an introduction. A few years ago, it literally was, because not everybody was doing CT parathyroid imaging. And of course, I want to show you one of my best results that I ever got with 4D CT. And if you look on the right axial, somehow in copying these talks from place to place and for indication, the arrows on the left have moved a little bit. But on the right side, those arrows are pointing to normal parathyroids. Usually the thought has been you can't see a normal parathyroid, only enlarged ones, which quite frankly was helpful because you wouldn't worry about the ones that you can see. But it's been reported that up to 40% of well-done 4D CTs, you can see normal parathyroids. And you've got to be very careful about that you're not misdirected or confused about what your target is for your surgery. But here are some normal parathyroids on the next slide. On the upper right, well, on both sides, you can see normal parathyroids. And, you know, the question might come in your mind, well, how do you know those are normal parathyroids? Which, if you go over to the right bottom slide and you see a red arrow, that is, this is, again, a great case. This was a CT that showed 4 normal parathyroids and a 5th, so a supernumerary parathyroid, less than 1% event. That was an ectopic location. I mean, this made my day, it made my week, made my month. And this case went just so well because this was ectopic and prevertebral, and as a result of having this information and using this surgically in surgical planning, I didn't even go into the thyroid bed because I ended up getting an appropriate intraoperative PTH drop. I didn't feel the need to explore those. I went right after the target through a posterior lateral approach, avoided the risk of thyroid bed directly, and was able to identify the bogey, take it out, and we'll talk a little bit about some of that process. And that was a successful surgery. So things you need to do when you're evaluating these patients preoperatively, obviously is do a good history, physical exam. Laryngoscopy is the king element of all preoperative evaluations of any central neck surgery. Pre and I would argue even post-operative laryngoscopy, so you know what your true incidence of paresis is and whether it's temporary and whether it's permanent. And stay tuned, there's going to be some new good literature coming out from the endocrine section of the American Head and Neck Society in the next year or so about some redefinitions of some terms and how they interact with this type of surgery as far as pre and post-operative diagnosis. Imaging on these patients should really be done after they've been referred with the possibility of the diagnosis of disease. And the reason for that is really the surgeon should order their scan of preference. And what's going to make their scan a scan of preference? Well, the one I guess they like the best, the one they find easiest to interact with in the OR, whether they like to project on a big screen or what have you, but also what is the best one performed at that particular center. Not all centers I have found have been able to master 4D CT scanning. I'm not sure why that is. I've got some ideas, but this, I think, allows for the best image to be used in the hands of the surgeon, which is who you want to have optimized in doing your parathyroid surgery. There are several ways and different surgical approaches and other surgical procedures that need to be considered in parathyroid surgery. I'm mainly going to focus on minimally invasive radioguided parathyroidectomy, sometimes called MERP. It's an outpatient procedure. It can be done under local with an LMA, which is sort of a local plus. It can be done with endotracheal anesthesia, which is the way that I do the vast majority, and allows for intraoperative nerve monitoring, which is also another talk. Routine frozen section is done by Sun. We wrote a paper about 15 or 20 years ago where we did a prospective study comparing pathologist identification using all their tools versus a well-trained set of surgical eyes and just using visual inspection, and both had a 95% identification rate on the day of surgery, and both were comparable. So that goes towards, I think, surgical training and how frozen section is not really commonly necessary. I'm a big advocate of intraoperative PTH testing. I think that's very helpful. That's another talk. I, in my practice, will give a preoperative technetium-99 sestamibi injection. I don't use that for imaging because I use 4D CT. I use that for the purpose of making the parathyroid relatively radioactive to the thyroid gland and to the background, and that allows as a confirmatory test. If the lesion that you remove ex vivo is over 20% of your measured background radiation, that by definition is your offending hyper-functioning parathyroid gland. And again, from the same publication I referred to, we did some comparative analysis, and minimally invasive at that time, where it was more of a technique performed in few centers with a smaller amount of literature written, was comparable to the other conventional techniques, and I would argue those numbers are as good, if not better, now. So I wanted to go through a difficult case where some of these preoperative curveballs presented themselves, and I've titled this "How to Avoid a Reoperative Case," because I can tell you in my practice, I have seen this case presented to other folks that perhaps were less experienced in this area, and they ended up with a failed surgery, and then they became a reoperative patient. And your success rate, I'm going to tell you about that, and complications are much improved if you're not doing this in a reoperative setting. So here's a 75-year-old female with a 2.5-year history of hypercalcemia, and those are her numbers, and those were her ultrasound findings. And this patient, apparently by their first surgeon, was thought to have a borderline case, and I'm not exactly sure why. Perhaps because the PTH wasn't sky high and paired with the calcium, but they did have an ultrasound finding that was consistent with a parathyroid lesion. So they were sent for a planar cystectomy, and as you can see, without overreading it, this was non-localizing. And they were sent for a 4D CT scan. Now, this is what's different. This patient never was a re-op patient. This was a primary patient because with the negative cystectomy and the, quote, borderline parathyroid lapse, they were referred to me. Now, I did what I would always do, which was get a SPECT CT cystectomy, because we didn't start doing routine 4D CT scans until late 2013, and this case was before that time. Well, it was actually around that time, but if you look on the SPECT CT cystectomy, which we started doing in 2009, which was a significant improvement over planar CT or planar imaging, or even SPECT cystectomy imaging. This was also non-localizing. So this then led us to a 4D CT, and this was one of our 20 original patients that we reported, or 21 original patients that we reported when we made our transition to 4D CT. And if you look at that, I guess it would be burnt orange arrow there, you can see that there is a small little lesion in the tracheoesophageal groove, which is a classic place that these lesions are missed, is deep in the TE groove. I can't tell you how many revision parathyroid surgeries that I've done where if the previous surgeon had gone 1 or 2 millimeters deeper into the TE groove, they would have found this. And I think a lot of that historically was driven by fear of going deep in the TE groove, perhaps not using monitoring or not being comfortable with monitoring, and in a virtuous effort to avoid damaging the recurrent laryngeal nerve, but the unintended consequence of missing the parathyroid lesion. Here, it's much more permanent. You can see on the coronal plane, and these deeper ones in the TE groove tend to be a little more superior, as you can see on this coronal image, although that superior location can be somewhat artifactual because of posture. In any case, these were our intraoperative findings. The baseline was baseline 1 was 3,300. Baseline 2 is 7,000. Now, the difference in these baselines was not time, it's position, and this was part of some research data that we were collecting. It's not important for the purposes of conversation, but the baseline was very high, in the thousands. The fat, we excise a dollop of fat to provide us access when we do small access surgery, and we take that, put that specimen on the back, and we use that as a negative control, and in this case it was 50. And then this low-lying the left superior thyroid, which was ectopically placed or located, turned out to have almost baseline 1. So As I told you, you wanted 20% more of baseline. This was almost 100% of baseline. So this was a very robust demonstration of using radio-guided surgery. So that in and of itself could confirm you got the offending target, no need for intraoperative parathyroid. Well, I'm an academician, I work in an academic center, and I'm sort of a belt and suspenders guy. And so if you look at the intraoperative parathyroid, you look at the baseline, which was 61, which wasn't particularly high. So again, this patient probably was a borderline case from the laboratory sense. Post-excision 26. One, that was done in 10 minutes, 20 minutes post-excision, that was 18. So the Miami criteria would say greater than a 50% drop into the normal range, which it already was, so because it was a borderline case. There you have it. You have a confirmed surgical cure intraoperatively of your hyperparathyroidism. So the results came back. This turned out to be 470 milligrams. And just in case you're not aware, a normal parathyroid weighs 50 milligrams. So this was almost 10x size by weight. And we always would see patients back between 10 and 20 days. I will tell you, I'm probably not going to do this in the post-COVID era because I've gotten much better at telemedicine. But this was also research-driven because we had some hypothesis about how a lot of failed surgery was going unrecognized because they were never being followed up properly. We would follow up all our patients, again, 10 days to 2 weeks after surgery and then 1 year after surgery with our routine parathyroid lab testing battery. And as you can see, the PTH is normal, the calcium is normal. The ionized calcium is a little elevated, and that's probably, well, I will tell you it's not probably, it was elevated because they were still on perioperative prophylactic calcium carbonate. Vitamin D at this era of testing was a little low normal, and the patient had a reduced glomerular filtration rate. So they had a little chronic renal insufficiency, which was probably an element, but not the principal element of their parathyroid dysfunction. So this transitions me to one of my favorite slides, reoperative parathyroid surgery. The greatest challenge in parathyroid localization is to localize a good parathyroid surgeon. This John Dotman was a radiologist at the National Institutes of Health, and his whole career was built on intra-arterial catheterization, collection of blood samples to localize where parathyroids were based on collection and then a subsequent analysis for parathyroid hormone. And I think this gentleman, although he never communicated that we were going to have advances in radiology technology that were definitely going to help us. But I think it underlines the concept that even with all of the technology that we have, surgeon experience, surgical approach, surgeon thought processes, and surgeon decision making is really key in success in this field. Another quote I want to share with you, and there I am in the center about 5 years ago between Orlo Clark, who's quoted, he's the tall gentleman, an icon of American and really global endocrine surgery from the University of California, San Francisco. And then on the other side, that is Paolo Miccoli, who is from Italy, and he is a world-famous endocrine surgeon who developed MIVAT, among other things, minimally invasive minimally invasive endoscopic thyroid surgery. I'm getting the acronym wrong, but pardon me, it's early in the morning. The quote that I want to share with you is up on the left side. Repeat parathyroid exploration is associated with more complications and fewer errors compared to initial explorations and should only be undertaken by an experienced endocrine surgeon in a center that can provide expert preoperative localization, so the advanced radiology, adjunctive intraoperative tools. That would be whether it was radiolocalization intraoperatively or intraoperative PTH, and cryopreservation when necessary. And hopefully I've emphasized those points to you in the talk up to this point. As we're winding down, whenever you see a reoperative case, you always have to ask yourself, do we have the underlying disease correct? Is this hyperparathyroidism? It's very important to review what's been done in order to appreciate what needs to be done. You may be able to use the same surgical approach. Just the fact that it's reoperative does not contraindicate a minimally invasive approach. Doing venous sampling and all the interventional radiology that Dr. Doppman created, first of all, it's not available in widespread across the United States. It requires special training, and practice makes perfect, as it does with anything. So really, it ends up becoming a testing regime of last resort. Ultimately, with the information that you've gathered from above, you're going to be able to base your surgery on solid imaging, your knowledge of anatomy and embryology, and your previous experience. I just want to point your attention to a recent paper where the American Head and Neck Society, in conjunction with the British Association of Endocrine and Thyroid Surgeons, have come up with consensus guidelines on the approach to the reoperative parathyroid patient, and I think you might find this to be useful. So I'd like to conclude by just you all thinking about how we started the talk, which is there's a lot of hypercalcemia out there that isn't being appropriately evaluated. Therefore, they're not getting the requisite follow-up testing. And therefore, they're either being never diagnosed or they're being diagnosed much later. And as a result of that, they're getting more advancement of the diseases related to the acceleration of disease that we outlined from untreated hypercalcemia. I will tell you, it is very sad and not uncommon that I will see patients referred to me for parathyroid surgery for the first time after their heart attack. Now, if the parathyroid surgery had been done earlier, would I have saved them for the heart attack? Maybe so, maybe not. You never know that. I've also seen many people referred to me after their debilitating hip fracture with significant accompanying morbidity to have their parathyroid surgery. I just took care of a very prominent a very prominent physician in the healthcare world who was getting ready to have hip surgery done, and during the preoperative evaluation was noted to be hypercalcemic, and was smart enough to stop the hip surgery process, get the hypercalcemia evaluated, and get his parathyroid surgery done. Now, why do I tell you that? Well, think about this. When you're having any type of big orthopedic surgery and you're having implants in your skeleton, would you rather have the plates and screws and the pins put into an osteopenic or osteoporotic skeleton, which might continue on in that condition for an undetermined amount of time until hyperparathyroidism was ultimately diagnosed or treated? Or would you rather have those pieces of hardware put into a healing skeleton? I think most people would choose the latter, not the former. And he was able to get his parathyroid surgery done successfully, then proceed on to his orthopedic surgery, and has been doing well and has returned to his pre-morbid occupation and work. So I'd like to thank you all for your attention and for your participation. I would say to take home a point, this is a slide I took from one of my primary care talks, but it applied to residents, it applied to even otolaryngologists out in training. Don't ignore hypercalcemia. Consider hyperparathyroidism if you have a patient that crosses your path that has stones, especially calcium-containing stones. And I'm not saying all stones. If a person has stones, then and they don't know that they're calcium stones, they need to be evaluated to make sure they're calcium stones. But if they have calcium stones, you need to be thinking of hyperparathyroidism. Consider hyperparathyroidism in people who are osteopenic and osteoporotic. And high calcium is a risk factor for cardiovascular and cerebrovascular disease if left untreated. If you're interested in some further material on this, you can search my name in PubMed and certainly search the topic in PubMed. There's a presentation that I gave available through Audio Digest, Lessons I've Learned as a Parathyroid Surgeon, which might be instructive as well. There's also how-to surgical articles that are out there that we've been involved with over time. And we have a textbook that I think is about 2 years old that is 600 pages and really is A to Z on the topic of parathyroid disease. And there's some surgeries on YouTube as well. Thank you for your attention. I'm done with my presentation, and Dr. Comer, our moderator, I don't know if he wants to open up his line and open up for questions. I think we have about 10 minutes left.
Sure. Thank you very much, Brendan. That was fantastic. That's a vast topic, and did a great job of summarizing that in a little less than an hour. For any of our folks who are listening out there, if you have any questions at this point, please either I will verbalize them over Zoom, and then so those are recorded when we put the recordings up on the website. Give them just a few seconds here, Brendan, to see if we've got any questions that come up.
You bet. Thank you very much for your kind words.
Okay. Here's a question. If you have a patient with one test showing hypercalcemia, what is the recommended length of time to wait before obtaining a second test?
That's an excellent question because, as you noticed, and that was deliberate, I didn't put an interval time, either minimum or maximum. And to my knowledge, that hasn't been put out as a recommendation by any specialty society. And if you think about it, that is so hard to control because sometimes these people are popping in for their annual physical with their primary care physician. Sometimes these are just coming up incidentally on a preoperative laboratory eval for some other surgery that they're planning on doing. So I would say just repeat it, whether it was a year ago or 2 weeks ago. Just repeat it. If you are not comfortable, let's say it was 2 weeks ago and it's still hypercalcemic and you're not comfortable with that, then repeat it 2 weeks later so that you have it over a month or a couple of months. But I think the key is that it's sustained over time, but we don't have any specific guidance as to what that period of time is.
So, any other questions out there by our viewers or listeners? Okay. Not seeing any come up. So I think you've covered it very well. And again, we appreciate you being here, Dr. Stack. Great summary.
Thank you, Dr. Comer. My pleasure. And perhaps offline, if you wanted some other targeted endocrine ones, you can let me know, and I can do those in the upcoming weeks.
Okay. Very good. Appreciate it. Thank you.
Okay, you take care.